So I also want to thank Jason and the organizers of MOAS for inviting me. I'm feeling my age because I see a lot of my former fellows in academia and pharma and in practice here. So funny story is that when I was at City Hope with Joe Chow, he used to be called Young Chow, and I was called Old Chow. Now I'm very old Chow. So today I'll speak to you about sarcomas and my disclosures. There's outline, introduction to sarcomas. I'll talk about soft tissue sarcomas, and then move to bone sarcomas to finish up. So sarcomas, are very rare tumors. They arise from transformed connective tissues. There's a little over 13,000 estimated cases in 2022. Crude mortality rate about 39% based on the number of deaths. And in bone sarcomas, even rarer, 3,900, and a crude mortality rate a little bit higher at 54%. So I always like to put a face to this disease. Former president of Venezuela, Hugo Chavez, he passed from rhabdomyosarcoma. His famous quote was he followed President George W. Bush at the UN, and the quote there, yesterday the devil came here, right here, and it smells of sulfur still today. I still laugh at that quote. For those who are a little bit younger, Virgil Abloh, he is the artistic director of Louis Vuitton, and he founded Off-White Fashion House. He recently passed from cardiac angiosarcoma. So sarcomas disproportionately affect younger individuals. In the decade of the 90s, it accounted for 11% of all cancers in children's and adolescents, and it's the fourth most common cancer in young adults, being under the age of 40. The problem here is that there's more than 70 different types of soft tissue sarcomas. Most are located in extremities, a third located in lower extremities, and the rest are distributed throughout the rest of the body. Staging is based on size, nodal status, and presence of metastasis or not. But in addition, it's also based upon the grade of the tumor. So we have grade 1 through grade 4. So T size is 5, 10, and anything over 15 as the cutoffs. So prognosis on the left is based, this is from the French cancer centers. They showed the prognosis on metastasis-free survival based upon the grade. So on the top is grade 1, on the bottom is grade 3. There is a grade 4, but that's strictly reserved for Ewing sarcoma. And on the right, sarcomas was the very first nomogram ever published. This is from the Memorial Sloan Kettering group, showing that points were awarded for various factors, including the size, the depth, the site, the subtype, and the age. And they're awarded, you're given points for these various prognostic factors, and they predicted a 12-year sarcoma-specific death, not survival. So you can see on the second to bottom is if you had a low-grade tumor and if you had a high-grade tumor at the very bottom. So this was back in 2002. This is all online now. So if you have a patient, you can go on the Memorial Sloan Kettering website and download that and plug in the prognostic factors, and you can present to your patient. Here, I just want to emphasize that the treatment of soft tissue sarcoma is surgery, surgery, surgery. Got to get the patient to surgery. That's the only curative modality. Other modalities, radiation is a benefit, and I'll show you what the effects of chemotherapy are in a second. So just to go way back here, just taking a holistic approach, this was the NCI randomized study of radical which was amputation, radical surgery, versus conservative or limb preservation surgery plus radiation. So it was a phase 2 randomized trial, 2-to-1 to limb preservation versus amputation. So in the amputation arm, there were 16 subjects. In that amputation arm, of course, there was no local recurrences. So when I say, of course, you have no extremity, you have no recurrence. For those who were randomized to conservative surgery, there were 27 subjects. 4 had a local recurrence. So the disease-free survival was disease-free recurrence was survival was 85%. So, but those patients were salvaged with the amputation. Importantly, the last 2 points are metastasis-free survival between the 2 arms was absolutely no difference. So 5 years was 71% versus 78%, and overall survival, the most important point is, again, no difference, 83 versus 88%. So you can see on the curves on the right, the disease-free survival, because of the local occurrences, favored amputation, but you can see the overlapping curves for metastasis-free survival and overall survival. So now, what is the role for adjuvant chemotherapy? So up until 2012, sarcoma oncologists all believed that adjuvant chemotherapy would be of benefit. And so we relied finally on this very large European trial, the ORTC, 62-9-31 of adjuvant chemotherapy versus observation. So over 350 patients were randomized to 5 cycles of doxorubicin and ifosfamide, so-called AIM, an acronym from adriamycin, ifosfamide, and mesna, versus observation. The distribution of the types of sarcomas, were pretty, what we would expect, 15% leiomyosarcoma, 13% liposarcomas, 11% malignant fibrous histiocytoma, which we now call undivergent polymorphic sarcomas, and 11% were synovial sarcomas. So those are synovials tend to happen in younger individuals, and they're one of the most chemosensitive of our soft tissue sarcomas. The distribution, 2/3 were in extremities, remainder distributed in the trunk and the pelvis. 40% were larger than 10 centimeters. 73% of the patient randomized to chemotherapy completed the prescribed 5 cycles of chemotherapy, and of that, 63% without any dose reduction or delay. Disappointingly, the 5-year recurrence-free survival was 53% for observation and 55% for chemotherapy. And just as importantly, overall survival, there was no difference. Here are the curves for this study. Overall survival on the left, recurrence-free survival on the upper right, a local regional recurrence on the lower left, and development of metastasis on the lower right. So curves are essentially superimposable. Here's the forest plot, looking if there was any subtype factor that might favor chemotherapy. The only one that looked had any potential difference was isolated limb perfusion. That's where you isolate the vessels going to an extremity, perfuse heated, usually melphalan. In Europe is TNF-alpha, but TNF-alpha is not available here in the United States. Maybe favored adjuvant chemotherapy, but again, that's primarily in Germany what they do. So given that statistics, what do we do for patients who develop metastasis? So again, as I said, surgery, surgery, surgery. So it's lung metastastectomy. So the International Registry of Lung Metastasis was reported back in 1997. They had over 2,000 sarcoma cases and looked at those patients who underwent pulmonary metastectomy. And they found the 5-year overall survival of 37% and a 10-year overall survival of 26%. And when they looked at the risk factors for recurrence after pulmonary metastectomy, the factors that were found were risk of recurrence was incomplete resection, if you had a high number of metastases, i.e. 4+, and also the disease-free interval. So disease-free interval is the time from the primary resection to the time of development of pulmonary metastasis. And updated report was from the Thames Cancer Registry in the UK. They had 1,357 pulmonary metastaectomies over a 3-decade period. Up to 10 or more thoracotomies were performed, and in their report, the 5-year overall survival for patients undergoing pulmonary metastaectomy for soft tissue sarcomas was 25% and 34% for bone sarcomas. So, whereas 50% of all primary sarcomas will be cured with multimodality therapy, unfortunately, the other half will eventually develop metastasis. And there's no curative treatment for patients with advanced sarcomas without surgery. So for those patients who cannot proceed to pulmonary metastaectomy, what are our statistics? The 2-year survival is less than 25%, and the 5-year survival is less than 10%. So for those patients then with who are ineligible for pulmonary metastaectomy, or you're trying to get them to a pulmonary metastaectomy, we do offer chemotherapy. And so this is another very large EORTC trial, 6/2012. Patients were randomized to single-agent doxorubicin, and the dose is 75 milligrams per meter squared, and that's kind of the standard dosing for soft tissue sarcomas. Or they were randomized to combination chemotherapy of doxorubicin plus ifosfamide. Again, the doxorubicin is 75 mg per meter squared. Ifosfamide was 10 grams per meter squared, the very dose-intensive chemotherapy. And you can see the outcomes on the right side. For the doxorubicin arm, the objective response rate was 13.6%. For AIM chemotherapy, it was 26.5%, so doubling of the response rate. Just below that, the median progression-free survival for doxorubicin alone is 4.6 months, and for the combination is 7.4 months. But note the bottom point, overall survival, doxorubicin alone, 12.8 months, combination 14.3 months, so that was not statistically significant. So based upon this study, the standard of care for most patients with metastatic soft tissue sarcoma who require chemotherapy remains doxorubicin alone. So you may have seen the use of gemcitabine and docetaxel. We usually reserve that for second line. So the GITTIS study is a UK study of moving gemcitabine and docetaxel upfront versus doxorubicin. So the previous EORTC study was published first. This followed. So they're randomized to gemtax versus doxorubicin. The dosing you can see, doxorubicin 75 per meter squared, gemtax 675, day 1 and 8, docetaxel 75 on day 8, and given every 3 weeks. You can see on the left, the median progression-free survival was essentially the same. Overall survival was essentially the same. But if you look on the curve at the bottom here, there is a bit of a separation here after 36 weeks favoring doxorubicin. So based upon this study, at least in the UK, the British still feel that doxorubicin is the first-line standard of care, and I agree. Pazopanib, also known as Votrient, is approved as FDA approved for patients with soft tissue sarcoma, with the exception of liposarcoma, who have received at least one frontline chemotherapy or are chemotherapy ineligible. So in this study, the Palette study, this is a global phase 3 study for soft tissue sarcomas, again excluding liposarcomas because they are insensitive to this treatment. They're randomized in a 2-to-1 fashion to pazopanib versus placebo. You can see that the progression-free survival on the top favors pazopanib versus placebo, 4.6 months versus 1.6 months. Overall survival was not statistically significant. And based upon the Palette trial, this was FDA approved back in 2012. Trabectedin is a drug that's Haviland. It's used for breast cancer, and investigators looked at its use for, particularly for liposarcomas or leiomyosarcomas. So you can see that the control arm is dacarbazine, a very, very old drug, has about a 5% response rate. Rarely used anymore nowadays, but that was a control arm versus trabectedin. You can see that progression-free survival favored trabectedin. There was no difference in overall survival. But you can see that in the forest plot that when they looked at leiomyosarcomas, this is, yes, trabectedin, not Irvine, this is Yondelis. So leiomyosarcomas, it favored trabectedin. It also favored liposarcomas, but it was a particular type of liposarcoma, and it's the myxoid round cell that made up most of the liposarcomas that benefited from this. Response rate was about 10%. PFS was tripled from 1.5 months to 4.2 months. Here's eribulin. I apologize. Again, this is a breast cancer drug, and this is, again, for patients with advanced liposarcomas or leiomyosarcomas. Again, the comparator was dacarbazine, and you can see in blue, this is the overall survival favoring eribulin over dacarbazine. The progression-free survival was almost overlapping. So the PFS, there was no difference, but the overall survival was favored the eribulin by 2 months, and that was statistically significant. You look at the forest plot, it was only for the liposarcoma subset that benefited. Leiomyosarcomas across unity. So based upon this trial, eribulin is approved for patients with recurrent liposarcomas after frontline chemotherapy. So chemotherapy has modest benefit. What about immunotherapy? So this was addressed in the Sarcoma Alliance for Research through Collaboration, or SARC-28 trial. This is a open-label phase 2 trial. They had several cohorts. Soft tissue sarcomas included leiomyosarcomas, N equals 10, UPS sarcomas, liposarcomas, and synovial sarcomas. They also did bone sarcomas, which were chondrosarcomas, Ewing's, and osteo. You can see the response rate here for overall partial response rate for soft tissue sarcomas was 15%, but it was primarily in the UPS sarcomas and the liposarcomas that benefited. There was 1 out of 10 synovial sarcomas that demonstrated a partial response. For the bone sarcomas, 1 patient responded out of 5, so accounting for a slightly higher response rate, but we really don't feel that it benefits patients with chondrosarcoma. They closed that cohort early. So basically, for 2 subtypes, UPS sarcomas and D-divergent liposarcomas, it may be a benefit. So can we hone in on which of those subtypes might benefit the most? So this is a Nature Medicine paper that was just recently published in June. So this is from the European group, and they also looked at pembrolizumab in soft tissue sarcomas. Originally, in their first attempt at using unselected patients with soft tissue sarcoma treated with pembrolizumab, their overall response rate was only 2.4%. However, if you looked for what are called tertiary lymphoid structures, basically the tertiary lymphoid structures look like lymph nodes within the soft tissue sarcoma. You can see the staining. It looks like a germinal follicle. So if you have those present in pathology in your tumor and you're treated then with pembrolizumab, the response rate increased from 2.4% to 30% in patients with tertiary lymphoid structures. So this is This is the report. So potentially a marker for a response to immunotherapy. I'll move now on to bone sarcomas. So we have three types of bone sarcomas. The first is chondrosarcomas. Conventional chondrosarcomas account for 90% of all chondrosarcomas. Most are low grade, grade 1 or 2, 90% with a low metastatic potential. Up to 10% are grade 3 and do have high metastatic potential. Up to 86% of these cases have mutations in the isocitrate dehydrogenase gene, a oncometabolite gene. Why is that important? Because IDH1 inhibitors, ivosidenib, has been tested in this and showing, although there were no responses, this is from William Tapp at Memorial, there was prolonged disease-free survival with ivosidenib. Dedifferentiated chondrosarcomas are conventional sarcomas that have secondary dedifferentiation and look like an osteosarcoma because they're dimorphic now with either an osteosarcoma or UPS features. And chemotherapy has now been recommended by the NCCN Bone Cancers Committee. Mesenchymal chondrosarcomas are rare. They're also dimorphic, but instead of a osteosarcoma or UPS-like feature, they have small blue round cells that look like a Ewing sarcoma. And it's an NCCN 2B recommendation to receive Ewing sarcoma-based chemotherapy. Unfortunately, with this disease, late recurrences are observed. An 18-year-old patient that recurred at age 28. So 10 years later, he recurred with pulmonary metastases. And clear cell is another rare subtype. Moving on to osteosarcomas, the vast majority are conventional osteosarcomas. They are intramedullary and they're all high grade. Surface osteosarcomas are divided into parosteo or low grade or periosteo, which are intermediate grade. Chemotherapy is absolutely recommended for these conventionals, and it's arguable, but most people will give for periosteal osteosarcoma. Chemotherapy should not be given for a parosteal osteosarcoma. So the EURAMO study is a European American osteosarcoma trial. All patients who were 30 years of age or less who presented with osteosarcoma localized received 2 cycles of MAP chemotherapy, which is high-dose methotrexate, adriamycin, and platinum. And then patients, we all know that when you resect the tumor after neoadjuvant chemotherapy, the pathologist looks at the percent necrosis. Your aim is to have more than 90% necrosis of the tumor. If patients in this trial if they did not reach 90% necrosis, they were randomized to continue the same chemotherapy, MAP chemotherapy, or adding ifosfamide and etoposide to the MAP chemotherapy postoperatively. You can see the 3-year event-free survival was no difference, P equals 0.8, and 3-year overall survival was, again, no different. And so based upon this trial, changing chemotherapy postoperatively to add 2 other agents does not benefit patients with osteosarcoma with less than adequate necrosis. Ewing sarcoma is the second most common sarcoma in children and adolescent and young adults. In the bone, it's typically diaphyseal versus metaphyseal for osteosarcoma. It's again characterized by reciprocal chromosomal translocation, creating a novel fusion gene, the EWSFLI1 chimera. And 10 to 20% of cases are extraskeletal. This is a patient of mine. She was diagnosed with Ewing sarcoma with this when she presented at 34 weeks of intrauterine pregnancy. She delivered, and then we treated her afterwards and did very well. So how do we treat Ewing sarcoma? It's basically 5 drugs, vincristine, doxorubicin, cyclophosphamide, alternating with ifosfamide etoposide. So this is a Children's Oncology Group trial reported in 2012 by Rich Woolmer. Patients with localized Ewing sarcoma were simply randomized to the standard arm, which is treating every 3 weeks for 2 cycles, local control, and then additional adjuvant chemotherapy, or the same overall number of chemotherapies treated every 2 weeks. So it's basically dose compression. So regimen B. So again, total number of chemotherapy cycles was exactly the same, but just based on dose compression. The 5-year event-free survival improved from 65% with a standard arm to 73% with a dose compression arm. Also improved overall survival. Again, it's barely statistically significant. So for patients with localized Ewing sarcoma, we always try to do dose-dense chemotherapy with every 2 weeks. Usually towards the end, because it's 14 cycles overall of chemotherapy, your bone marrow kind of poops out here, and so usually end up doing every 3 weeks for the last few cycles. And that's kind of a quick tour de force of sarcomas. Again, a very rare cancer, and I'm happy to answer any questions you might have.